So we've already discussed a lot of aspects of 3D planning this morning, and I'm going to talk a bit more about it as it relates to reverse shoulder arthroplasty. So we have evolved to where we have 3D planning, and multiple different software companies can offer that. So in contrast to what we did, say, when I was a fellow, and this was only in its infancy, this software is able to analyze multiple points in the scapula, give us patient-specific options in terms of planning. In the blueprint system that many of us use, automated segmentation happens, which saves time and helps your workflow, as we discussed a little bit earlier. And it has the potential to help your hospital staff and your hospital in terms of reducing inventory and giving pretty accurate predictions of which implants you're going to use. And that helps my rep, because my rep can see online ahead of time what I've planned, because I'm usually planning a couple of weeks in advance. But, you know, in reality, we've always had pre-op planning to a certain degree. Every one of us pre-op planned even before the softwares were there, in terms of spending time looking at imaging, looking at the x-ray, getting a CT, had probably become pretty standard of care for most of us before the 3D planning software has evolved. And now we have all these add-ons as well, and you can jump off of this continuum at any point. Gilles Volch was asked, well, how about surgeons who don't want a 3D plan? You know, operating still based then on knowledge and experience, but is my knowledge and experience the same as everybody else's? We have wide variation, and so I think the planning softwares can help eliminate the variation by having a consistent process in that. So why plan? Why use these softwares? I like to think about it in terms of understanding what I'm dealing with, and then also allowing me to optimize the implant position, help me execute better and translate my plan into the actual surgery. And then the plan is also the foundation that's allowing us then to use these further tools and enabling technologies. And so some examples of understanding what you're dealing with using planning software, some of the more complex cases, revision situations. It's nice to be able to really look in depth at the case in detail before you have to deal with it in the operating room, figure out whether or not there's an issue on the glenoid side, when obviously the bigger challenge is on the humeral side in this particular case. George just mentioned the reverse shoulder angle, or the RSA angle. You may look at a case like this and think that it's pretty straightforward. This patient had a weak subscap, and I was thinking about a reverse, and it looks like the inclination is only 6, but then when we look at the RSA angle, it's 12, and so you have to think a little more carefully how you're going to avoid superior tilt of the base plate. And I think maybe before we had pre-op planning, we were missing out on some of this information, and so it's helpful in figuring out how we're going to address it. And then the add-on things such as, for example, PSI guides can help us to execute better. In a case like this, where there's severe bone loss, young patient with juvenile rheumatoid and very medialized glenoid. And I think it would have been really difficult to understand this case well without having some 3D planning. First of all, to just get a better look at the anatomy and to understand exactly what we had left and what we didn't. So again, that understanding what you're dealing with, and then actually planning. In terms of the reverse, I think there's very little other option in this case, even though she's young. We still in Europe don't have the patient-matched implants that were mentioned. This case is from a couple of years ago, before those were out anyway. And we were thinking about bone versus metal. Do you go custom implant or do you use bone? In a young patient, we were hoping that by using a bone graft and doing a bio-RSA, that would incorporate, and later down the line, you know, we should have more bone to work with should she need a revision. This particular software also allows us to plan where we're going to put our screws. And then the software will simulate range of motion. I think you have to be careful with this. You know, there are limitations to this. The scapula is fixed and it's not taking into account soft tissue tension. So the way that I use the range of motion simulation is really to just compare different options. So it's sort of a relative comparison rather than the absolute numbers. That's not necessarily the range of motion the patient's going to get, but it shows if I change one thing about my plan and then look at the range of motion, that's sort of how I use that. It's helpful as well to understand your sort of custom bone graft through the planning software. The patient-specific instrumentation guide was really helpful in this case because her glenoid was just so tiny and so medialized, it was really hard to find enough real estate to actually fit the post down the middle of the glenoid. And I think without a PSI guide, it would have been hard to reproduce the plan. And so this ended up being really helpful in the case. We did look at whether we had more than 1 centimeter of post-in-native bone, and we did not, and so therefore we staged it. So we did the hemi-reverse that George was talking about, but with the plan to go back and then do the humerus once the bone graft had incorporated. So at about 4 months after the first stage, we went ahead and did the second stage. And so pre-op planning really helped us with this case and made it less daunting. There are multiple tools out there from different companies in terms of reusable patient-specific guides, optical navigation, all of these things that help us translate our plan into the surgery. We can now plan for revisions, so planning for reverse also now includes dealing with revisions and again sort of understanding what's going on in the case and then making a plan that you can execute. For example, this patient had a 4-part fracture when he was 38 years old, presented to me 2 years later. He's now 40. He's got a hemi that's put in extremely retroverted and no tuberosities, very poor function and pain. And so some of the pre-op planning is still the 2D x-rays and understanding length and getting x-rays of the opposite side, and then using the planning software to plan the revision to reverse, getting a look at his CT scan and understanding what we're left with in terms of bone. We think the glenoid's fine. Is it really okay? And what are our challenges going to be on the humeral side? In the interest of time, we'll sort of skip on through this a little bit. Planning the glenoid, similar to what George has talked about, but obviously, again, in this case, bio-RSA is not an option, so I'm looking to lateralize. And I can compare these options. That's where I use that range of motion sort of feature, bearing in mind that it's not necessarily reflecting exactly the clinical reality. The thing with these software programs, you can keep on lateralizing and distalizing and make that range of motion look better. And I think that's the thing for young surgeons who, are coming to this with the software being always available since they've begun doing arthroplasty. You've got to remember that there's soft tissues, there's the brachial plexus, there's tension on the acromion, so there is a limit to what you can do. And the software is not going to tell you that. You have to still be the surgeon and remember that. And then we can also plan on the humeral side, and we've probably spent less time, paying attention to the humerus, but now that we're planning revisions to reverse, I think it's going to force us to think more about the humerus. What I do find helpful is sort of looking at the different options and looking at the bone that I've got left. And so when you subtract the implants and you really see, the humerus bone best case scenario, because remember, after you extract what's in there, you may not have left what's actually on your CT scan. So it's sort of showing you at best case what you'll have left on the humeral side. And so again, you can sort of put it all together and simulate a joint. But I think you do have to, as I keep saying, take that with a pinch of salt and use it as a relative measure rather than absolute numbers. Executing the plan, we have mixed reality technology now, which allows you to see your plan in real time as you operate. And so on the revision side, this can be helpful when you're doing a revision reverse because we can't get PSI guides. This case didn't have a particularly challenging glenoid, but it was still nice to be able to confirm visually that where I thought I wanted to put my pin did seem to be where I was actually putting it. It's also helpful to be able to see your imaging, and everyone else in the room can see what you're seeing as well. And so this can be really helpful for your assistants and for teaching your fellows. So it's another aspect of the planning, and that's how he ended up. So the reasons, again, to plan: understanding what you're dealing with, optimizing the position, which we hope should translate into better longevity of our implants. We don't have evidence of that yet, and I think it's going to take time to be able to show that. It may be that the advantage is only in the more complex cases, but if you reserve the planning technology and any of the add-on execution tools for the really difficult cases, then you don't have a level of comfort or familiarity with them if you haven't gotten good at using them in the straightforward cases, and that's why I like to plan all of my cases. The plans then become the foundation that allow us to use all of these tools that are coming out, not just the PSI guides, but also the patient-matched implants, which are sort of halfway between our standard implants and full-on custom. And I think that's something that's been helpful in a lot of cases in North America where it's available, so we look forward to having that here. And then the mixed reality and being able to actually navigate based off of the MR instead of just eyeballing, and ultimately robotic shoulder replacement. So the future of pre-op planning, there's already artificial intelligence, like in so many other parts of life, built into some of these software programs. In the Blueprint program, you'll get a prediction of anatomic versus reverse based on what a panel of experts would have done, taking these factors into account. And one of the features in development is auto planning, so suggested plans for your case. I think this is useful, but again, you still have to make your own decision for the patient that's in front of you. You can't let the software, even if it is driven by experts in the background and AI, I think you can't let the software tell you what to do. Mixed reality has been something interesting in the past 2 years that we've started using, and I think as we learn to integrate that into navigation, that's going to be something that helps us be more accurate. Matthias Zumstein has already shown on a cadaver study that this does translate into us placing our implants more accurately. And ultimately, if you have a pre-op plan, then you can have a plan to tell the robot what to do. But ultimately, the surgeon should always be the one in the driving seat. Thank you.